So questions regarding imaging, PET scanning, surgery, recovery, go for it. We have some of the world's experts here. I can get started with the conversation. So why don't we start with Dr. Cooker? A lot of my patients ask me, should we get PET scan to monitor the disease? And there's a lot of myths about that PET scan is better. Of course, PET scan has advantages over CTs and MRIs, but on the contrary, CTs and MRIs can also have advantages over PET scans. Would you like to elaborate? What do you like to prefer to do for monitoring?
Definitely. So I think, that's kind of why when I gave a talk about the imaging studies, I kind of separated into anatomical and functional studies. PET scans are really very useful because we get a lot of functional information about them. But the one drawback to the PET scan is that sometimes we can't really evaluate the size very well. So the CT scan is actually really the most important study so that we could precisely measure the lesions and then determine the response based on that. Remember when I said that 30% reduction in size or the 20% increase in size? Those measurements are really obtained from a CAT scan because with the contrast, we could really well define the lesions, and it provides very high resolution. The PET scan, though, gives you functional information, but the drawback is that we don't really have that really fine detail as to the measurement of the lesion. So they're both complementary, and they both serve their own roles. But they, so, I mean, Aman, for your patients, what would you prefer to follow up?
So I agree with you, Dr. Cooker. So when it comes to monitoring the disease or to test whether the drug's working or not, all we really need or we care about is the tumor shrinking or growing or remaining stable. That means the actual measurements. And for those purposes, like Dr. Cooker mentioned, anatomic scans like CTs or MRIs are the best because the PET scan often is not able to tell us the actual measurement. That's what really matters. When we are uncovering the disease, when we are newly diagnosed patient, we are trying to find the extent of the disease burden, PET scan is really good. So every patient should get a PET scan at the baseline. And anytime there's sort of a change in the disease burden and we are thinking about PRRT. But for routine monitoring, you get a very good assessment with the measurements from either CT or MRI. What is important is that the CT scan is a triple phase or a multi-phase CT scan because neuroendocrine tumors are vascular tumors. If you don't get all the phases, you'll miss the disease. Or if you're doing MRI, then especially for liver, we now have specific liver protocol, liver contrast, MRIs. That's really, really beneficial.
One other comment. So in patients who might be surgical candidates, actually the PET scan is actually very helpful because there could be lesions that are very tiny and you may miss them on a CAT scan, but they might show up very nicely on the PET scan. So patients who are possible surgical candidates and we want to stage them before to see if the disease has spread to other organs, the PET scan is very helpful because it can identify very tiny lesions that we might overlook on a CAT scan.
Fantastic. Alrighty, let's switch our gear and ask some exciting surgical questions. Dr. Merchant, this one's for you. What should come first, PRRT or surgery? Looks like we're going to have to wrestle this one, right?
So it all depends. There's no two patients that are the same. And I think a lot of these factors, all of these options that we talk about, there's a timing to all of this. It depends on the extent of the tumor in the liver. It depends on how symptomatic a patient is. Is the tumor isolated just to the liver or is it in other areas? So there's a lot of factors involved in this decision making. A lot of times we'll have tumor just in the liver and the patient is stable for a long period of time. We may do nothing. We may just observe it for a while, and patients can have stable disease in the liver for a long period of time also. So it's a lot of combination of things. There's no one right answer or one like textbook approach. And I think that's kind of the importance of being in a center where you have a multidisciplinary team of doctors that are kind of assessing each patient and evaluating the appropriate timing of individual therapies. But in general, if it's limited tumors in the liver and we feel we can remove them, then we try to do surgery to try to remove them all. But as I said, it's almost always going to come back.
Right. And I agree with you, Dr. Merchant. The second part of the question was, is there any problem in operating after PRRT? Now, last week, our Italian colleagues presented their data in this setting where they treated patients with pancreatic nets in early stage who otherwise would have gotten straight into surgery. They gave PRRT before to shrink the disease and then later did the surgery. So they did not report that there was any issues with doing surgery after PRRT in that subset of patients. And they were able to show that 50 to 60% of patients showed disease shrinkage. However, I'm not convinced that at this point in time we are ready to do PRRT before surgery in early stage cancer. Because if the disease is resectable and is in early stage, we should not waste time. We should go for the resection with an intention of curing the patient. However, if the patient's already advanced and the cancer's already spread, yes, then we have to factor in which goes first. Is there role of surgical debulking versus PRRT versus other therapies? And I have to tailor the treatment to individual patients. All right. Dr. Nguyen, the next
Can
one.
I just add one thing to that? So we're just early in trying to understand surgery after PRRT. PRRT is generally done when the tumor is more advanced in multiple locations, or the liver is full of tumor where we're not going to be able to do surgical resection. It makes sense in a way to try to see if it's more effective in earlier resectable patients, because as I said, we're removing what we see. There's always other cancer cells there that we can't see, and that's why these tumors come back. And perhaps, I don't know the answer, nobody in the world knows the answer, but we'll see. And I think the study that he just described, we'll see if the recurrence rate is decreased with PRRT up front in more earlier stage disease, then maybe it is helpful, but we'll have to see. But, studies in neuroendocrine tumors, they take decades because these tumors are so slow growing and patients live for so long. So it's going to take some time to figure that out.
Gotcha. Thank you, Dr. Merchant. So, Dr. Nguyen, tell us a little bit about surgical approaches in thoracic nets. Now, you showed us a picture where you're kind of operating on this device, the robot. What's the advantage of doing that over, let's suppose, a conventional open surgery? And what is the sort of like real world experience in terms of patient like recovery time? How long do they have to stay in the hospital? What can they expect in terms of recovery for breathing, shortness of air, etc.?
Right, thank you. So depend on the situation and the location, tumor, and the complexity of the tumor. For early stage tumor in the lung itself without involvement in the central airway, we like to do surgery using the robotic system. It is a form of we call minimally invasive surgery. You heard in the past VATS, video-assisted thoracoscopy, and now it is a form of VATS, but we use a robot as an intermediary between me and the patient. It gives me 3D views, good lighting, and magnifications. And I don't have to make big incision in the chest to get in. You never see our hand inside the chest at all. Everything that we do is through the small instrument about the size of my finger. The advantage is less trauma. We achieve the same oncologic outcome. We achieve the same kind of operation we do open when we compare similar patient population. And certainly with less pain, less incisions, people recover faster. And actually, we have a program where we do nerve blocks. We do different kind of pain management strategies, and people do go home in a day or two after surgery like this. We have seen patients going home without narcotics at all. So yes, it is advantageous if we can do surgery without making big incisions. On the other hand, if I have to do a complex operation where I have to reconstruct the airway, for example, the case I showed to you, the tumor occlude the airway. I have to open the patient so I can get control of the vessels, control the bronchus, reconnect the bronchus, then I would rather do it open. Again, with our new perioperative protocol, patients do go home reasonable time, 3 days instead of 6. and the complication rate is much lower. So we choose the operation based on the features and the need of the operation.
Wonderful. Great. Thank you, Dr. Nguyen. Dr. Cooker, next one's for you. So this is regarding a disease, a type of neuroendocrine cancer we didn't really focus on for today's meeting, the high-grade neuroendocrine cancer, the NEC. If you remember my slide, NET versus NEC. So these are your small cell lung cancers, large cell neuroendocrine cancer, poorly differentiated neuroendocrine cancer, very aggressive cancer. The question is, do we do copper 64.8 scan in these NEC or neuroendocrine carcinoma patient? And if we do, is there a role of PRRT for these high-grade neuroendocrine cancer patients?
Good question. The higher grade neuroendocrine cancers don't have very much uptake on dotatate. The very poorly differentiated, I guess one of the latest study that I had read is about 40% have some uptake, but that doesn't also describe the degree of uptake. So to be eligible for a PRT, we like to, when we look at the uptake in the lesions, we like them to be higher than the liver. That's kind of our guideline that we have respond to PRT the best. So there might be some uptake on a dotatate scan in these high grade neuroendocrine carcinomas. They typically are not very good candidates for PRT because the intensity of uptake is not very high. So in those patients, as far as imaging goes, we usually do FDG PET scans because that will actually give us a lot of information about how much metabolic activity the lesions have. And then also CAT scans, because CAT scans will also show us in detail where the lesions are located and how they're changing over time. But in general, higher grade neuroendocrine, at least poorly differentiated neuroendocrine tumors don't have very high affinity on the dotatate scan, which would imply that they don't respond very well to PRT. Now, if you want to talk a little bit about the NER2.
Yes. So, so typically the answer should be yes. Do not get somatostatin receptor imaging or dotatate imaging in poorly differentiated neuroendocrine cancer. And sometimes our colleagues in community, they mix up the two and they do the wrong PET scan for the wrong subtype. So very, very important for a low-grade NET or a well-differentiated NET, always need to have a dotatate PET. And poorly differentiated is a FDG PET. It's a different type of PET scan. However, we are now realizing that there is a smaller group, maybe about 20% of these NECs that may express somatostatin receptors. So for those patients, we are opening not one, but a couple of clinical trials testing PRRT for NECs, but this will be a highly selected group, and this is not ready for prime time yet, so this will be done under a research protocol. But there might be few patients with NEC who might have somatostatin receptors, and if they do, then we can consider it from PRRT. But it's right now not the conventional way to treat. Great. Next set of questions, I'm going to lump them up together because they're very they revolve around pancreatic surgery, Whipple's, recovery period, and more specifically, difference between Creon, Zenpep, and papaya seeds. So Dr. Merchant, you want to take all those together? Risk of infection, recovery time after Whipple's surgery, and should somebody go to a local hospital for Whipple, or is this something that you really need to see a high volume center?
Yeah, so those are all great questions. Pancreatic surgery is complex surgery. There is an inordinate amount of data now over the last 2 decades that complex surgeries like Whipple's, stomach surgery, rectal cancer surgery, liver surgery, esophageal surgeries, these are all complex and have a significant risk of morbidity after the operation. And if they're done in low volume centers, the risk of complications is significantly higher. The risk of dying from the procedure is significantly higher. More importantly, in the best of hands, a Whipple procedure, about 1/3 of patients will have some post-op complications in the best centers. The difference between recovery is being able to handle and manage the complications after they occur. Because we see such a high volume of patients and we have dedicated interventional gastroenterologists, interventional radiologists, and radiologists that can help us with the management, these patients recover. When a center just does a few of these, they don't have the additional expertise that sees these complications routinely, and therefore the recovery, even if you have a complication, can lead to bigger disasters. So in general, when you're going to have these complex surgeries, it's always better to go to a high volume center. The other difference when you're dealing with cancer, whether it's neuroendocrine cancer or any other type of cancer, the other important thing is you go to a center that has a multidisciplinary team of physicians that is very focused on that one type of cancer. Like at our center, if you have breast cancer, you're not seeing any one of us, right? If you have lung cancer, you're seeing Dr. Nguyen. If you have GI, pancreas, you're seeing me. And we're working with Dr. Chauhan, Dr. Hussein, Dr. Kuker, our pathologists, our gastroenterologists. We're all meeting every week to discuss all of these patients. And as we have discussed many times, there is no one-size-fits-all approach here. Every cancer is different, every patient is different, so discussing it amongst a team that is going to determine the timing of various treatments and things makes a huge difference.
Thank you so much. This next question, Dr. Nguyen and Dr. Merchant, you can also chime in. So one of the things that NETs patients have to be aware of is carcinoid crises. Now, majority of NETs patients are non-functional. That means their tumors are not secreting too much of hormones, be it serotonin and other hormones. But there is a 10 to 15 to 20% patients who have high serotonin. And excess of serotonin can lead to carcinoid syndrome, and too much of it can lead to carcinoid crises. Okay, so we have to be very careful about that situation. Now, how do we prepare for it or anticipate it preoperatively, intraoperatively? Do you make any accommodations for that during your surgical procedures?
Fortunately, for lung neuroendocrine tumor, we don't see a lot of those. It's very uncommon. I mentioned about the Cushing's disease, Cushing's syndrome. That came out of the National Cancer Institute, where I used to be, and they report 64 cases over 30 years. So these are the very uncommon presentation of lung neuroendocrine tumor. So if I don't know if the patient has neuroendocrine tumor, and during our process patient evaluation, we always ask standard questions. Do you have any high blood pressure? Do you have any palpitation, things like that? But most of the patients say no, then most likely they don't have a functional tumor. If the patient comes to me with a diagnosis of neuroendocrine tumor, certainly I will focus on that a bit more, about diarrhea, palpitation, flushing, things like that. But it's very uncommon for us as thoracic surgeon to deal with it. More for Dr. Merchant team to deal with, like the appendiceal neuroendocrine tumors and GI tract. They are functional, but not for lung. Very uncommon.
So in general, the majority of the patients that have syndrome is because of the bulk of tumor they have in their body. And usually it's when it's already spread to the liver and the liver has a large amount of tumor. And that's why you see a lot of serotonin being released, and that's why you have the syndrome. So all of these patients are managed medically first with somatostatin analogs. This is where Dr. Chauhan tries to come in and try to control those symptoms, but many times that's not adequate. And these are the situations where we will many times go in and try to debulk or take out as much tumor in the liver as we can, because the less burden of tumor there is, the less serotonin that's being released, so the symptoms can improve. So in that situation, we would go in and try to remove as much of the tumor in the liver.
Wonderful, great. Question to Dr. Kuker. I have to give a shout out to him. I cannot function the NET tumor board without his help. He is a wealth of knowledge. Not only is a nuclear medicine doctor, but is also was a body radiologist. So I get to have both expertise reviewing our CT and MRIs, and also then the dotatate PETs with him. So Dr. Kuker, regarding MRIs, is there a particular preference on the type of contrast that we like to do, especially for the liver? And we can start with that, and I had a follow-up question to that.
That's a good question as well. There are different contrast agents that we have for MRI. The contrast agents, the main principle of using contrast is because of that increased blood flow that we see in most neuroendocrine tumors. There is a special type of contrast. It's is called a hepatobiliary contrast agent, or Eovist is the brand name, if you've ever heard of it before. But that provides an additional phase. So for most, when we order a triple phase CT or MRI, the three phases are an arterial phase, venous phase, and a delayed phase. But with this special Eovist contrast, we get an additional fourth phase, which looks at it's a biliary phase. We're actually looking at the liver parenchyma, or the liver tissue itself. And that gives us additional information, because if a lesion is not may not have that classic, hyper enhancement that we see with contrast, we could still identify if it's a tumor or not based on that last hepatobiliary phase. So it is important. If you don't have that hepatobiliary phase, is it going to make a big? Is it going to change how we interpret the study? It depends on the circumstance. It's not routinely given for every patient. It's very helpful in patients, for example, who have cirrhosis, because in those patients we can see a lot of different things that are going on in the liver, and that really helps us to identify lesions that are normal and abnormal. But in the absence of cirrhosis, in cirrhotic patients, we give it more routinely. In patients who just have normal, don't have a very advanced liver dysfunction, then we tend to give just a regular contrast media. But the EOVS does give, in special circumstances, give us additional information.
Wonderful, wonderful. And with that, our time is over. We just have one lingering question, and I'll quickly wrap this up. If you find an incidentalloma, do we measure serum serotonin in an asymptomatic patient? Usually, in the current age where we are so reliant on scans and scopes and blood tests, we're moving away from our skills as history takers and physical examination. But in NETs, we still have to keep that intact. So it's really important to kind of elicit that history. Is it patient's tumor secreting too much insulin? So that would present with low sugar symptom, hypoglycemia symptoms. Patients presenting with high serotonin, so flushing, wheezing, diarrhea, joint pains, fatigue, etc. So you really have to elicit that history and an appropriate physical exam. But if the patient is asymptomatic, usually we don't have to run the blood biomarkers, because those are not an accurate way to monitor the disease. We will still depend on the scans to guide us whether the tumor is growing or not. So in an asymptomatic patient, many times in our high volume center, we are also a research center, we do a baseline biomarker testing, which includes organ specific net biomarkers. So if it's a pancreatic, we might do a baseline, VIP or gastrin, things like those. If it's a mid-gut, we might do a baseline serotonin, but we might not necessarily repeat them if they are negative. But it's honestly not even necessary in some cases if it's completely asymptomatic. With that, we would like to conclude. Thank you so much to our excellent speakers and panelists here.